Question 1. The analysis reveals a significant increase in patient complaints related to delayed response times in a specific geographic zone over the past quarter. Which of the following represents the most appropriate next step in data-driven quality improvement for this EMS agency operating under U.S. federal and state regulations? Option A. Immediately reassign additional ambulances to the affected zone to proactively address potential future delays, without further investigation into the root causes of the current increase. Option B. Implement a public relations campaign to inform the community about the challenges faced by EMS in meeting response time targets without altering current operational procedures. Option C. Initiate a comprehensive review of dispatch logs, GPS data, and crew reports for the affected zone to identify specific contributing factors to delays, such as traffic patterns, call volume fluctuations, or resource allocation issues, and then develop targeted interventions based on these findings. Option D. Focus on improving the documentation of response times by crews to ensure more consistent data entry, assuming the current increase is primarily a reporting artifact. Correct answer is C. Initiate a comprehensive review of dispatch logs, GPS data, and crew reports for the affected zone to identify specific contributing factors to delays, such as traffic patterns, call volume fluctuations, or resource allocation issues, and then develop targeted interventions based on these findings. Explanation. The analysis reveals a critical need to interpret complex EMS data to improve patient outcomes and operational efficiency. This scenario is professionally challenging because it requires not just data aggregation, but also the discernment of meaningful trends, the identification of potential biases in data collection, and the application of this understanding to actionable strategies within the strict regulatory confines of U.S. EMS. The decision-making process must prioritize patient safety, adherence to federal and state EMS regulations, and the ethical imperative to provide the highest quality of care. The correct approach represents best professional practice because it involves a systematic, evidence-based methodology for data interpretation. It prioritizes identifying root causes of observed trends, considering the impact of external factors, and proposing interventions that are both clinically sound and compliant with regulations such as those from the National Highway Traffic Safety Administration, NHTSA, for data reporting, and the Centers for Medicare and Medicaid Services, CMS, for reimbursement and quality metrics. This approach ensures that data-driven decisions are robust, defensible, and ultimately beneficial to the patient population served. An incorrect approach that focuses solely on superficial correlations without investigating underlying causes is professionally unacceptable. This fails to address the true issues, potentially leading to ineffective or even harmful interventions. It also risks violating regulatory requirements for data-driven quality improvement, which mandate a deeper understanding of performance metrics. Another incorrect approach that overlooks potential data collection biases, such as variations in reporting by different crews or at different facilities, is also professionally flawed. This can lead to skewed interpretations and misallocation of resources. Ethically, it represents a failure to ensure data integrity, which is foundational to responsible EMS practice. A third incorrect approach that proposes interventions without considering regulatory feasibility or impact on patient care is also unacceptable. This demonstrates a lack of comprehensive understanding of the EMS system and its constraints, potentially leading to non-compliance and adverse patient events. Professionals should employ a decision-making framework that begins with clearly defining the data analysis objectives. This involves formulating specific questions the data should answer. Next, rigorous data cleaning and validation are essential to ensure accuracy. The analysis phase should move beyond simple descriptive statistics to inferential analysis, exploring correlations and potential causal relationships while acknowledging limitations. Crucially, the interpretation must be contextualized within the operational and regulatory environment. Finally, proposed actions must be evaluated for their clinical efficacy, operational feasibility, regulatory compliance, and ethical implications before implementation. Question 2. Benchmark analysis indicates that the most significant evolutionary shift in emergency medical services, EMS in the United States, fundamentally reshaping its structure, regulation, and delivery, was characterized by Option A. The proliferation of specialized EMS units, including air medical services and tactical EMS teams, to address specific patient populations and operational environments. Option B. The establishment of early, often volunteer-run ambulance corps and rescue squads in urban and rural areas prior to the mid-20th century. Option C. The rapid adoption of advanced medical technologies, such as automated external defibrillators and advanced airway devices, beginning in the late 1980s. Option D. The transition from a predominantly hospital-based, physician-directed model to a community-integrated, pre-hospital care system driven by federal legislation and funding. The correct answer is D. The transition from a predominantly hospital-based, physician-directed model to a community-integrated pre-hospital care system driven by federal legislation and funding. Explanation. Scenario analysis. This scenario presents a professional challenge by requiring an EMS administrator to critically evaluate the historical development of EMS in the United States and its impact on current service delivery models. The challenge lies in discerning which historical developments have had the most profound and lasting influence, necessitating a deep understanding of the regulatory, technological, and philosophical shifts that have shaped EMS from its nascent stages to its present form. Accurate judgment requires moving beyond superficial knowledge to a nuanced appreciation of cause and effect within the evolution of the field. Correct approach analysis. The correct approach accurately identifies the shift from a hospital-centric, physician-directed model to a community-based, integrated system as a pivotal moment in EMS history. This transition, driven by legislative mandates like the Highway Safety Act of 1966 and subsequent federal funding initiatives, fundamentally altered the scope of practice, training requirements, and the very definition of EMS as a distinct entity. It fostered the development of standardized protocols, professionalized the workforce, and laid the groundwork for the modern EMS system that emphasizes pre-hospital care as an integral part of the healthcare continuum. This aligns with the historical trajectory and regulatory underpinnings of EMS development in the U.S. Incorrect approaches analysis. One incorrect approach might focus solely on the technological advancements of the late 20th century, such as the widespread adoption of defibrillators or advanced airway management. While important, these are largely consequences of the broader systemic and philosophical shifts, not the primary drivers of the evolution itself. This approach fails to recognize the foundational changes in governance and service delivery that enabled the effective integration of these technologies. Another incorrect approach could emphasize the early, often volunteer-driven, ambulance services of the pre-1960s. While these were the precursors to modern EMS, their impact on the current structure and regulation of EMS is less direct than the post-1960s federal initiatives. This approach overlooks the transformative period of federal involvement and professionalization that truly defined modern EMS. A third incorrect approach might highlight the development of specialized EMS units, e.g., air medical, tactical EMS, without acknowledging the broader evolution of the core EMS system. These specialized units are extensions and refinements of the fundamental EMS framework, rather than the core evolutionary leap that established the framework itself. Professional reasoning. Professionals should approach historical analysis by identifying the key inflection points that led to fundamental changes in the structure, regulation, and delivery of EMS. This involves understanding the interplay of legislation, societal needs, technological innovation, and professional development. A robust understanding of these drivers allows for informed decision-making regarding current EMS challenges and future strategic planning, ensuring that interventions are grounded in the historical context and regulatory landscape of U.S. EMS. Question 3. Risk assessment procedures indicate that an EMS crew has responded to a call for a patient experiencing shortness of breath. Upon arrival, the patient, who is alert and oriented, states they are not experiencing significant discomfort and wishes to remain at home, refusing transport to the hospital. The patient appears to understand the potential risks of not seeking further medical evaluation. What is the most appropriate course of action for the EMS crew? Option A. Immediately transport the patient to the nearest emergency department, as shortness of breath always warrants hospital evaluation regardless of patient preference. Option B. Advise the patient that their refusal is not in their best interest and attempt to persuade them to accept transport, overriding their wishes if necessary. Option C. Conduct a thorough capacity assessment to ensure the patient understands their condition, the risks of refusing transport, and the benefits of transport. And if capacity is confirmed, document the informed refusal and provide appropriate patient education. Option D. Document the patient's refusal of transport without further assessment, assuming the patient is making a competent decision. Correct answer is C. Conduct a thorough capacity assessment to ensure the patient understands their condition, the risks of refusing transport, and the benefits of transport. And if capacity is confirmed, document the informed refusal and provide appropriate patient education. Explanation. Scenario analysis. This scenario presents a significant professional challenge due to the inherent conflict between patient autonomy and the perceived best interest of the patient, complicated by the legal and ethical obligations of EMS providers. The patient, though exhibiting signs of distress, is refusing transport, creating a dilemma where the EMS provider must balance respecting the patient's right to refuse medical care against the potential for serious harm or death. If the refusal is based on impaired judgment or lack of understanding, the legal framework in the U.S. governing EMS mandates adherence to patient rights, while also requiring providers to act within their scope of practice to prevent harm. Correct approach analysis. The correct approach involves a thorough assessment of the patient's capacity to make an informed decision. This includes evaluating their mental status, understanding of their condition, the risks and benefits of transport, and the alternatives to transport. If the patient is deemed to have capacity, their informed refusal must be respected, and appropriate documentation is crucial. This aligns with the ethical principle of patient autonomy and the legal right to refuse medical treatment, as long as the patient is competent. The EMS provider's role is to provide information and care within their scope, not to coerce or override a competent patient's decision. This approach upholds the patient's rights, while mitigating legal risk for the provider through diligent assessment and documentation. Incorrect approach is analysis. One incorrect approach would be to immediately transport the patient against their will, even if they appear distressed. This violates the principle of patient autonomy and could lead to legal repercussions for battery or false imprisonment. It fails to acknowledge the patient's right to refuse care, a fundamental tenet of medical ethics and law in the U.S. Another incorrect approach would be to simply document the refusal without a comprehensive capacity assessment. This is a failure to meet the professional standard of care. If the patient later suffers adverse outcomes, the EMS provider could be found negligent for not adequately assessing their ability to make an informed decision, thereby failing to protect the patient from potential harm. This neglects the ethical duty to ensure the patient's decision is truly informed and voluntary. A third incorrect approach would be to dismiss the patient's concerns and leave without offering further assistance or information, even if the patient is refusing transport. While respecting the refusal, this approach fails to fully discharge the EMS provider's duty of care. Best practice dictates offering alternatives, providing information about potential consequences of refusal, and ensuring the patient understands how to seek help if their condition worsens. This approach demonstrates a lack of thoroughness and potentially abandons the patient in a vulnerable state. Professional reasoning. EMS providers must employ a structured decision-making process that prioritizes patient safety and legal compliance. This involves 1. Initial assessment of the patient's condition and immediate needs. 2. Evaluation of the patient's capacity to make informed decisions, which includes assessing their orientation, comprehension, and ability to reason. 3. Clear and concise communication of the patient's condition. Proposed treatment transport, risks of non-transport, and alternatives. 4. Obtaining informed consent or informed refusal, with thorough documentation of the entire process, including the capacity assessment and the patient's expressed understanding. If capacity is questionable, protocols for involving medical direction or family should be followed. Question 4. During the evaluation of a critically ill patient with a suspected ST elevation myocardial infarction en route to the hospital, the EMS team has initiated advanced cardiac life support measures. Upon contacting the receiving hospital's emergency department, the EMS provider is informed by the charge nurse that the ED physician is currently occupied with another critical patient and is unavailable for direct consultation. The EMS provider has a clear understanding of the patient's condition and the necessary interventions according to established EMS protocols, Which of the following represents the most appropriate course of action for the EMS provider in this situation? Option A. Divert the patient to a different hospital that has a readily available ED physician for immediate consultation. Option B. Continue to attempt to reach the ED physician for a brief consultation to discuss the patient's critical status and confirm the receiving plan, while continuing to administer appropriate care. Option C. Proceed with definitive treatment as per protocol and provide a detailed report to the ED physician upon arrival, assuming the ED physician will be able to manage the patient effectively without prior consultation. Option D. Attempt to contact a cardiologist directly at the hospital to discuss the patient's case and obtain guidance on further management. The correct answer is C. Proceed with definitive treatment as per protocol and provide a detailed report to the ED physician upon arrival, assuming the ED physician will be able to manage the patient effectively without prior consultation. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medical services, EMS, where a patient's complex medical needs require coordination across multiple healthcare disciplines. The critical nature of the situation, coupled with potential communication barriers and differing professional perspectives, necessitates a structured and collaborative approach to ensure optimal patient care and safety. The challenge lies in integrating the expertise of EMS personnel, hospital emergency department staff, and potentially other specialists, while adhering to established protocols and patient advocacy principles. Correct approach analysis. The correct approach emphasizes direct, real-time communication and collaborative decision-making between the EMS team and the receiving hospital's emergency department physician. This aligns with established EMS protocols and best practices for interdisciplinary collaboration, as outlined by organizations like the American College of Emergency Physicians, ASEP, and the National Association of EMS Physicians, NEEPS, which are foundational to the ABEM EMS subspecialty curriculum. This direct line of communication ensures that the receiving team has accurate, up-to-date information to prepare for the patient's arrival, facilitates a smooth patient handoff, and allows for immediate consultation on treatment adjustments or further diagnostic steps. This approach prioritizes patient safety and continuity of care by leveraging the collective expertise of all involved professionals. Incorrect approach is analysis. One incorrect approach involves the EMS provider unilaterally deciding on the definitive treatment plan without consulting the receiving hospital. This violates the principle of collaborative care and can lead to suboptimal treatment if the hospital's resources or capabilities differ from what the EMS provider assumes. It bypasses the expertise of the emergency department physician, who has access to a broader range of diagnostic tools and treatment options, and can result in a disjointed care pathway, potentially compromising patient outcomes and violating professional standards of practice. Another incorrect approach is to rely solely on a pre-established, rigid protocol for all complex cases without considering the unique patient presentation or the receiving facility's capabilities. Protocols are essential. They are designed to guide, not replace, clinical judgment and interdisciplinary communication. Failing to engage in real-time dialogue with the receiving team can lead to a failure to adapt care to the specific patient's needs, potentially delaying critical interventions or misallocating resources, which is a failure in professional responsibility and patient advocacy. A third incorrect approach involves delaying communication until the patient arrives at the hospital, assuming the ED team can manage without prior notification. This is a significant failure in interdisciplinary collaboration and patient handoff. It prevents the ED from adequately preparing for the patient's specific needs, potentially leading to delays in critical interventions, increased patient risk, and inefficient use of hospital resources. This approach disregards the importance of proactive communication in ensuring a seamless and safe transition of care, which is a cornerstone of effective EMS practice. Professional reasoning. Professionals should utilize a decision-making framework that prioritizes clear, concise, and timely communication. This involves a structured patient report, e.g., SBAR situation, background, assessment, recommendation, when initiating contact with the receiving facility. The framework should also include a mechanism for active listening, seeking clarification, and collaboratively developing a plan of care that integrates EMS findings with hospital capabilities. When faced with complex cases, Professionals should not hesitate to engage in direct consultation with the receiving physician to ensure the best possible patient outcomes, adhering to the principles of teamwork and patient advocacy. Question 5. Operational review demonstrates a recent EMS response to a motor vehicle collision involving a single occupant who is found to be disoriented, smelling strongly of alcohol, and reporting no pain. The patient is able to follow simple commands but is verbally resistant to a full physical examination, stating they are fine and just had a few drinks. The vehicle sustained significant front-end damage. What is the most appropriate initial approach to this patient's assessment and management? Option A. Administer intravenous fluids and pain medication to sedate the patient, facilitating a more thorough examination once they are calmer. Option B. Rely on the patient's statement of feeling fine and the strong odor of alcohol as the primary indicators of their condition, and proceed with rapid transport to the nearest emergency department without a detailed physical assessment. Option C. Conduct a rapid primary survey followed by a thorough secondary survey, including a detailed head-to-toe physical examination and vital signs, while attempting to gain the patient's cooperation, and prepare for transport to a trauma center. Option D. Focus solely on the mechanism of injury and the strong smell of alcohol, assuming intoxication is the sole cause of altered mental status, and proceeding with transport without a comprehensive physical examination. The correct answer is C. Conduct a rapid primary survey followed by a thorough secondary survey, including a detailed head-to-toe physical examination and vital signs, while attempting to gain the patient's cooperation and prepare for transport to a trauma center. Explanation. Scenario analysis. This scenario is professionally challenging due to the inherent ambiguity in assessing a patient with altered mental status and potential intoxication following a significant trauma. The EMS provider must differentiate between the effects of intoxication and actual traumatic injury, which can be life-threatening if missed. The pressure to rapidly extricate and transport the patient, coupled with the potential for unreliable patient reporting, necessitates a systematic and thorough approach to avoid diagnostic errors. Correct approach analysis. The correct approach prioritizes a comprehensive trauma assessment, including a detailed primary and secondary survey, despite the patient's altered mental status. This aligns with established EMS protocols and the American Board of Emergency Medicine's emphasis on evidence-based trauma management. The principle of treat the trauma first is paramount, as intoxication can mask or mimic serious injuries. A thorough physical examination, including a neurological assessment, beyond what intoxication might explain, vital signs, and assessment for external signs of trauma, is crucial. This systematic approach ensures that all potential injuries are identified and addressed, minimizing the risk of undertreatment or delayed care, which is a core ethical and regulatory responsibility of EMS providers. Incorrect approach is analysis. One incorrect approach involves solely attributing the patient's altered mental status and unresponsiveness to alcohol intoxication and proceeding with rapid transport without a full trauma assessment. This fails to adhere to the fundamental principle of ruling out life-threatening traumatic injuries. Ethically, this constitutes negligence by omission, as it bypasses critical diagnostic steps. Regulationally, it violates standard EMS protocols for trauma patient management, which mandate a comprehensive assessment regardless of perceived contributing factors. Another incorrect approach is to rely solely on the patient's verbal assurances of feeling fine, despite objective signs of trauma and altered mental status. This approach is flawed because intoxication can impair judgment and the ability to accurately assess one's own condition. It neglects the provider's responsibility to conduct an independent, objective assessment. This represents a failure in professional duty of care and a deviation from best practices in trauma management. A third incorrect approach is to focus exclusively on the mechanism of injury without a thorough physical examination to identify actual injuries. While the mechanism is important for risk stratification, it does not replace the need to physically assess the patient for signs of trauma. This can lead to overlooking subtle but critical injuries. This approach is deficient in its diagnostic rigor and fails to meet the standard of care expected in trauma management. Professional reasoning. When faced with a trauma patient who may be intoxicated, the professional decision-making process should follow a structured algorithm. First, ensure scene safety and appropriate personal protective equipment. Second, conduct a rapid primary survey to identify and manage immediate life threats. Third, If the patient is responsive, attempt to obtain a sample history, but do not solely rely on it if altered mental status is present. Fourth, perform a thorough secondary survey, including a head-to-toe physical examination, paying close attention to signs of trauma, neurological deficits beyond what intoxication would explain, and vital signs. Fifth, consider the need for advanced airway management, fluid resuscitation, or other interventions based on the assessment findings. Finally, communicate all findings and interventions clearly to the receiving facility. The overarching principle is to assume the worst until proven otherwise, especially in trauma. Question 6. The risk matrix shows a potential for increased community health engagement if EMS providers offer routine blood pressure checks during non-emergency calls. Considering the established regulatory framework for emergency medical services in the United States, which of the following best defines the scope of EMS in this context? Option A. EMS scope is primarily determined by patient satisfaction surveys, which indicate a desire for broader health services beyond emergency care. Option B. EMS scope is flexible and should adapt to community needs, including offering preventative health services whenever an EMS unit is available. Option C. EMS providers should offer any requested service that could potentially improve community health, as long as it does not directly conflict with immediate life-saving interventions. Option D. EMS is defined by its role in providing pre-hospital assessment, treatment, and transport of patients experiencing acute medical emergencies, and does not encompass routine health screenings outside of an active emergency response. The correct answer is D. EMS is defined by its role in providing pre-hospital assessment, treatment, and transport of patients experiencing acute medical emergencies, and does not encompass routine health screenings outside of an active emergency response. Explanation. Scenario analysis. This scenario presents a challenge in defining the scope of emergency medical services, EMS, within a complex healthcare system. The core difficulty lies in distinguishing between emergent pre-hospital care, which is the undisputed domain of EMS, and services that, while potentially beneficial, do not strictly fall under the definition of EMS as regulated by the American Board of Emergency Medicine, ABEM, Subspecialty in Emergency Medical Services. Misinterpreting this scope can lead to misallocation of resources, potential patient harm due to inappropriate intervention, and regulatory noncompliance. The pressure to provide comprehensive care, coupled with evolving healthcare models, necessitates a clear understanding of established EMS definitions. Correct approach analysis. The correct approach aligns with the regulatory framework and guidelines for the ABEM subspecialty in emergency medical services by strictly adhering to the established definition of EMS. This definition typically encompasses the pre-hospital assessment, treatment, and transport of patients experiencing acute medical emergencies. It emphasizes the role of EMS in providing immediate life-saving interventions and stabilizing patients until they can be transferred to definitive care. This approach represents best professional practice because it ensures that EMS resources are utilized for their intended purpose, maximizing their effectiveness in critical situations, and maintaining compliance with federal and state regulations governing EMS operations and provider scope of practice. Adherence to this definition prevents the expansion of EMS into areas that are better served by other healthcare professionals or modalities, thereby safeguarding patient safety and the integrity of the EMS system. Incorrect approaches analysis. An approach that includes providing routine health screenings or non-emergent medical advice outside of an active emergency call fails to adhere to the definition of EMS. This is a regulatory failure because EMS is specifically designed for emergent situations, not primary care or public health outreach that can be delivered through other established channels. Ethically, it represents a misallocation of specialized emergency resources. Another incorrect approach would be to consider all patient interactions initiated by a 911 call as falling within the absolute scope of EMS, regardless of the nature of the call. This is a regulatory failure as it blurs the lines between emergency response and other public safety or social services. It can lead to EMS personnel being diverted from true emergencies to handle non-medical issues, potentially delaying care for those in critical need. Finally, an approach that prioritizes patient satisfaction surveys over established protocols and scope of practice for EMS personnel is a significant regulatory and ethical failure. While patient satisfaction is important, It cannot supersede the defined roles, responsibilities, and limitations of EMS as established by regulatory bodies. This approach risks compromising patient safety and the effectiveness of the EMS system by allowing subjective metrics to dictate operational decisions beyond the scope of EMS practice. Professional reasoning. Professionals should utilize a decision-making framework that begins with a clear understanding of the established definition and scope of EMS as outlined by relevant regulatory bodies, such as those governing the ABEM subspecialty in emergency medical services. This involves critically evaluating any proposed service or intervention against this definition. If a service falls outside the pre-hospital emergent care paradigm, it should be recognized as such. Professionals should then consider whether the service is more appropriately provided by other healthcare entities or community resources. This requires ongoing education and adherence to established protocols and guidelines, prioritizing patient safety and regulatory compliance above all else. When in doubt, consulting with medical directors, legal counsel, or regulatory agencies is a prudent step to ensure adherence to the defined scope of EMS. Question 7. Regulatory review indicates that effective emergency medical services operations are underpinned by robust risk assessment and management strategies, particularly concerning patient care documentation. Considering the American Board of Emergency Medicine Subspecialty in Emergency Medical Services Framework, which of the following approaches to documenting a complex patient encounter involving multiple interventions and a rapid transport best exemplifies adherence to regulatory requirements and professional best practices for risk mitigation? Option A. Prioritizing the speed of patient handoff by providing a concise verbal summary to the receiving facility staff and relying on colleagues to fill in any missing details in the written report later. Option B. Completing a detailed narrative of the patient's presentation, interventions administered, and the rationale for each decision, ensuring all vital signs and medication dosages are accurately recorded, even if it requires a brief extension of time post-patient handoff. Option C. Documenting only the patient's chief complaint and the final disposition, assuming that the receiving hospital's medical staff will capture all necessary details during their assessment. Option D. Focusing on the most critical interventions and omitting less significant details, such as exact times of medication administration or specific vital sign trends, to ensure the electronic patient care report is submitted within the mandated timeframe. The correct answer is B. Completing a detailed narrative of the patient's presentation, interventions administered, and the rationale for each decision, ensuring all vital signs and medication dosages are accurately recorded, even if it requires a brief extension of time post-patient handoff. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent tension between immediate patient care needs and the regulatory mandate for data collection and reporting in emergency medical services. EMS providers operate under strict protocols and legal frameworks that require accurate documentation for patient safety, quality improvement, and legal compliance. Failure to adhere to these requirements can have significant consequences, including compromised patient care, regulatory sanctions, and legal liabilities. The challenge lies in balancing the urgency of the situation with the meticulousness required for proper record keeping. Correct approach analysis. The correct approach, which involves documenting the patient's condition, interventions, and the rationale for decisions made, represents best professional practice because it directly aligns with the core principles of EMS operation and regulatory compliance. The American Board of Emergency Medicine Subspecialty in Emergency Medical Services Framework emphasizes thorough patient assessment and management, which necessitates detailed documentation. This documentation serves as a legal record, a tool for quality assurance, and a critical component of the patient's continuum of care. Adhering to established protocols for documentation ensures that all necessary information is captured, facilitating post-event review, research, and continuous improvement of EMS systems. This approach upholds the ethical obligation to provide comprehensive and accountable care. Incorrect approach is analysis, an approach that prioritizes speed over completeness in documentation, leading to the omission of critical details such as vital signs or specific medication dosages, represents a regulatory and ethical failure. This omission can hinder subsequent medical care, compromise the ability to analyze the effectiveness of interventions, and create a legally indefensible record. It violates the principle of accurate record keeping, mandated by regulatory bodies overseeing EMS. Another incorrect approach would be to rely solely on verbal reports to colleagues without creating a written record. While verbal communication is essential in EMS, it is insufficient as a sole method of documentation. Regulatory frameworks require a written or electronic record to serve as an official account of the patient encounter. Verbal reports are prone to misinterpretation, memory lapses, and are not legally binding. This failure to create a permanent record is a direct contravention of documentation standards. Finally, an approach that involves falsifying or inaccurately representing patient information to meet perceived reporting deadlines or to avoid scrutiny is a severe ethical and regulatory violation. This constitutes fraud and directly undermines the integrity of the EMS system and patient care. Such actions can lead to severe disciplinary actions, loss of licensure, and criminal prosecution. Professional reasoning. Professionals should employ a systematic approach to risk assessment in EMS documentation. This involves understanding the specific regulatory requirements for documentation within their jurisdiction, identifying potential points of failure in the documentation process, e.g., time constraints, equipment issues, provider training, and implementing strategies to mitigate these risks. A key element is recognizing that documentation is not an afterthought but an integral part of patient care. Professionals should prioritize accuracy, completeness, and timeliness, understanding that a well-documented patient encounter is crucial for patient safety, quality improvement, and legal protection. When faced with time pressures, the decision-making process should focus on capturing essential information accurately, even if it means a brief delay in completing less critical details, rather than omitting vital data or falsifying records. Question 8. The evaluation methodology shows that a paramedic crew arrives to find a 68-year-old male experiencing acute shortness of breath, audible wheezing, and accessory muscle use. His history is significant for severe COPD. His oxygen saturation is 85% on room air. Which of the following sequences of immediate interventions best reflects a process-optimized approach to this respiratory emergency, adhering to established EMS guidelines for managing a COPD exacerbation? Option A. Obtain a detailed 12-lead electrocardiogram (ECG) and administer intravenous fluids before assessing oxygenation status. Option B. Administer high-flow supplemental oxygen via non-rebreather mask, followed by nebulized bronchodilators, and prepare for potential non-invasive positive pressure ventilation (NIP) if initial treatments are insufficient. Option C. Immediately initiate endotracheal intubation to secure the airway and facilitate ventilation, then administer bronchodilators. Option D. Administer nebulized bronchodilators first, then assess oxygen saturation and administer supplemental oxygen if indicated. Correct answer is B. Administer high-flow supplemental oxygen via non-rebreather mask, followed by nebulized bronchodilators, and prepare for potential non-invasive positive pressure ventilation (NIP) if initial treatments are insufficient. Explanation. Scenario analysis. This scenario presents a common but critical challenge in emergency medical services: rapidly escalating respiratory distress in a patient with a known history of COPD. The professional challenge lies in quickly differentiating between a typical exacerbation and a more life-threatening condition, such as pulmonary embolism or pneumothorax, while simultaneously initiating appropriate interventions under pressure. The need for accurate assessment and timely, evidence-based treatment is paramount to patient survival and minimizing morbidity. The dynamic nature of respiratory failure demands a systematic yet flexible approach, considering the patient's baseline status and potential for rapid decompensation. Correct approach analysis. The correct approach prioritizes a structured assessment that integrates vital signs, patient history, and focused physical examination findings to guide immediate management. This aligns with established EMS protocols and guidelines, such as those promulgated by the National Association of EMS Physicians, NEMSP, and the American Heart Association, AHA, for advanced life support. Specifically, the prompt recognition of hypoxia and the immediate administration of supplemental oxygen, followed by bronchodilator therapy, directly addresses the pathophysiology of bronchospasm and airway inflammation characteristic of COPD exacerbations. The subsequent consideration of non-invasive positive pressure ventilation, NIP, or intubation, based on the patient's response and severity of distress, reflects adherence to best practices for managing severe respiratory failure. This systematic, protocol-driven approach ensures that critical interventions are not delayed and that the patient receives the most appropriate level of care based on their clinical presentation. Incorrect approach is analysis, an approach that delays oxygen administration while focusing solely on obtaining a detailed, lengthy history before initiating any treatment is a critical failure. This violates the principle of immediate life support and the recognition that hypoxia can rapidly lead to irreversible organ damage and death. EMS regulations and ethical guidelines mandate prompt intervention for life-threatening conditions. An approach that administers bronchodilators without first addressing significant hypoxia is also problematic. While bronchodilators are crucial, oxygenation is the immediate priority in a hypoxic patient. Failure to provide adequate oxygenation can worsen the patient's condition and hinder the effectiveness of subsequent treatments. This deviates from standard ALS algorithms that emphasize the ABCs: airway, breathing, circulation, with a primary focus on oxygenation, an approach that immediately proceeds to intubation without attempting less invasive measures like NIP, especially in a patient with a history of COPD, where NIP can be highly effective in avoiding barotrauma and improving outcomes, represents a potential overreach and failure to adhere to evidence-based guidelines for managing COPD exacerbations. Intubation carries its own risks, and its premature use without exhausting less invasive options can be detrimental. Professional reasoning. Professionals should employ a systematic approach that begins with scene safety and rapid patient assessment, focusing on the ABCs. This involves quickly identifying life threats, such as severe hypoxia or airway obstruction. Based on the initial assessment, immediate interventions should be initiated according to established protocols. Continuous reassessment of the patient's response to treatment is crucial, allowing for adjustments in the management plan. This iterative process of assessment, intervention, and reassessment, guided by evidence-based practice and regulatory frameworks, ensures optimal patient care in dynamic emergency situations. Question 9. Market research demonstrates that hospital providers often face challenges in managing pediatric airway emergencies, with a significant variability in approach and outcomes. Considering a 3-year-old child presenting with stridor, retractions, and increasing respiratory distress following a suspected upper airway obstruction, which of the following represents the most appropriate initial management strategy within the framework of the American Board of Emergency Medicine Subspecialty in Emergency Medical Services Regulatory Guidelines? Option A. Focus solely on oxygen administration and transport, deferring any airway interventions until arrival at the hospital. Option B. Immediately attempt endotracheal intubation using a size 4 uncuffed endotracheal tube, bypassing initial medical therapies. Option C. Administer a sedative and paralytic agent to facilitate immediate needle cricothyrotomy. Option D. Administer racemic epinephrine via nebulizer and prepare for potential advanced airway intervention if clinical status deteriorates despite initial therapy. The correct answer is D. Administer racemic epinephrine via nebulizer and prepare for potential advanced airway intervention if clinical status deteriorates despite initial therapy. Explanation. This scenario presents a professionally challenging situation due to the inherent uncertainty in pediatric airway management, the potential for rapid decompensation, and the critical need for timely and effective intervention. The challenge is amplified by the need to balance aggressive treatment with the potential for iatrogenic harm, all within the context of evolving clinical evidence and established protocols. Careful judgment is required to select the most appropriate airway management strategy based on the patient's specific presentation and the available resources, while adhering strictly to the American Board of Emergency Medicine, ABEM, Subspecialty in Emergency Medical Services, EMS, regulatory framework. The correct approach represents best professional practice by prioritizing a structured, evidence-based approach to pediatric airway management that aligns with established EMS protocols and guidelines. This involves a thorough assessment of the patient's airway patency, respiratory effort, and oxygenation status, followed by the selection of an intervention that is both effective and minimizes risk. The use of appropriate equipment, skilled personnel, and a systematic approach to airway management, including consideration of advanced airway techniques when indicated and feasible, is paramount. This approach is ethically justified by the principle of beneficence, aiming to provide the best possible care for the pediatric patient, and is legally defensible by adhering to the standards of care outlined by the ABEM-EMS subspecialty guidelines. An incorrect approach that relies solely on a single, unproven technique without adequate assessment would be a regulatory and ethical failure. This would violate the principle of non-maleficence by potentially causing harm through an inappropriate intervention. It would also fail to meet the standard of care expected of EMS professionals, as it bypasses the systematic evaluation and decision-making process mandated by professional guidelines. Another incorrect approach, such as delaying definitive airway management due to indecision or over-reliance on less invasive measures when the patient is clearly deteriorating, represent a failure of timely intervention, potentially leading to irreversible harm and violating the duty to act promptly in the patient's best interest. This could also be seen as a failure to adhere to the spirit of the ABEM-EMS guidelines, which emphasize decisive action based on clinical assessment. Professional decision-making in such situations should involve a rapid but thorough primary and secondary survey, focusing on the ABCs: airway, breathing, circulation. This should be followed by a systematic consideration of airway management options, ranging from basic maneuvers to advanced interventions, based on the patient's age, anatomy, and clinical status. A critical component is the continuous reassessment of the patient's response to interventions and the willingness to escalate care as needed. Adherence to local EMS protocols, which are typically informed by national guidelines and best practices relevant to the ABEM-EMS subspecialty, is essential. This framework ensures that decisions are not only clinically sound, but also compliant with the regulatory and ethical standards governing EMS practice. Question 10. Implementation of a standardized protocol for suspected diabetic emergencies in the pre-hospital setting presents an opportunity to improve patient outcomes. Given a patient presenting with altered mental status, diaphoresis, and a history of diabetes, which of the following pre-hospital interventions, if performed in isolation, best reflects adherence to best practices and regulatory guidelines for immediate management? Option A. Administer intravenous normal saline. Option B. Administer intravenous insulin. Option C. Administer oral glucose gel. Option D. Observe the patient and transport to the nearest emergency department. The correct answer is C. Administer oral glucose gel. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in EMS. Managing a patient with a suspected diabetic emergency in a pre-hospital setting where definitive diagnostic tools and immediate physician oversight are limited. The professional challenge lies in rapidly assessing the patient, differentiating between hypoglycemia and hyperglycemia, and initiating appropriate, safe interventions while awaiting definitive care. The urgency of the situation, potential for rapid deterioration, and the need to avoid iatrogenic harm, e.g., administering glucose to a hyperglycemic patient, demand careful judgment and adherence to established protocols. Correct approach analysis. The correct approach prioritizes rapid glucose assessment and targeted intervention based on that assessment. Administering oral glucose to a patient with a confirmed low blood glucose level is the most appropriate and evidence-based intervention in the pre-hospital setting. This directly addresses the immediate life threat of severe hypoglycemia, which can lead to seizures, coma, and permanent neurological damage. This approach aligns with national EMS guidelines and protocols, which emphasize prompt recognition and treatment of hypoglycemia as a critical intervention to restore cerebral function. It is ethically sound as it prioritizes patient safety and well-being by addressing the most immediate life-threatening condition. Incorrect approaches analysis. Administering intravenous insulin without confirming hyperglycemia and without physician order is a critical regulatory and ethical failure. Insulin lowers blood glucose. Administering it to a hypoglycemic patient would exacerbate their condition, leading to severe, potentially fatal hypoglycemia. This action violates the principle of do no harm and exceeds the scope of practice for most EMS providers without specific medical direction. It also bypasses essential diagnostic steps, demonstrating a lack of professional judgment and adherence to safe practice. Administering intravenous fluids without assessing blood glucose levels is an inappropriate intervention for a suspected diabetic emergency. While intravenous fluids may be indicated in certain hyperglycemic states, e.g., DKA, HHS, for hydration, they do not directly address the core metabolic derangement of hypoglycemia. In a hypoglycemic patient, this intervention would delay definitive treatment and could be considered a failure to provide appropriate care, potentially leading to a worse outcome. It represents a lack of targeted assessment and intervention. Observing the patient without any intervention until arrival at the hospital, despite signs suggestive of a diabetic emergency, is a failure to provide timely and appropriate pre-hospital care. EMS providers have a responsibility to intervene when a patient is in distress or has a potentially life-threatening condition. Delaying treatment for hypoglycemia can lead to irreversible neurological damage. This inaction constitutes a dereliction of duty and a violation of professional standards of care. Professional reasoning. EMS professionals must employ a systematic approach to managing suspected diabetic emergencies. This involves rapid assessment of the patient's mental status, vital signs, and, crucially, blood glucose levels if a glucometer is available. If hypoglycemia is confirmed, immediate administration of oral or intravenous glucose is indicated. If hyperglycemia is suspected and the patient is symptomatic, protocols may guide fluid administration and potentially insulin administration under medical direction. The decision-making process should always prioritize patient safety, adherence to established protocols and medical direction, and the principle of providing the most appropriate intervention based on the available data. Question 11. Process analysis reveals that an EMS crew is dispatched to a residence for a 35-year-old male found unresponsive with shallow respirations and pinpoint pupils. The patient has a known history of opioid abuse. The crew is considering several management strategies. Which of the following approaches best aligns with current U.S. EMS regulatory frameworks and best practices for managing potential toxicological emergencies? Option A. Administer naloxone immediately, secure a peripheral Roman IV, and transport to the nearest emergency department without further on-scene assessment. Option B. Administer a broad-spectrum antibiotic and intravenous fluids while attempting to locate a local hospital with a psychiatric unit for potential withdrawal management. Option C. Initiate a comprehensive physical examination, including detailed dermatological and orthopedic assessments, while awaiting further information from dispatch regarding the patient's medical history. Option D. Perform a rapid primary survey focusing on airway, breathing, and circulation. Obtain a brief history from available family regarding substance use and timing, and prepare for immediate transport to a facility capable of advanced toxicology management, considering activated charcoal if indicated and not contraindicated. Correct answer is A. Administer naloxone immediately, secure a peripheral Roman IV, and transport to the nearest emergency department without further on-scene assessment. Explanation. Scenario analysis. This scenario presents a significant challenge due to the rapid onset of symptoms and the potential for life-threatening complications in a patient with a history of substance abuse. The EMS provider must quickly differentiate between a primary toxicological event and other emergent conditions, while also considering the patient's underlying vulnerabilities and the potential for co-ingestion or withdrawal. The limited information available at the scene, coupled with the patient's altered mental status, necessitates a systematic approach to assessment and management, prioritizing patient safety and appropriate resource allocation. Correct approach analysis. The correct approach emphasizes a rapid, targeted assessment focused on identifying immediate life threats and gathering crucial information for definitive care. This includes assessing airway, breathing, and circulation, ABC, evaluating vital signs, and performing a focused neurological exam. Crucially, it involves obtaining a detailed history from any available witnesses or family, inquiring about the substance ingested, the amount, and the time of ingestion. This aligns with the National EMS Education Standards and the American Board of Emergency Medicine's focus on evidence-based practice in toxicological emergencies. The prompt administration of activated charcoal, when indicated and not contraindicated, is a cornerstone of decontamination in many poisoning scenarios, as supported by toxicology guidelines. The decision to transport to a facility capable of managing complex toxicology cases, including potential antidotal therapy and advanced life support, is paramount. This approach reflects best professional practice by prioritizing rapid stabilization, accurate diagnosis, and appropriate disposition to a higher level of care, minimizing morbidity and mortality. Incorrect approaches analysis. One incorrect approach involves delaying transport to initiate extensive, non-emergent diagnostic workups at the scene, such as attempting to draw multiple laboratory samples without a clear indication or performing prolonged physical examinations that do not directly address immediate life threats. This violates the principle of rapid transport for critically ill patients and can lead to delays in definitive care, potentially worsening the patient's condition. It also represents a failure to adhere to the time-sensitive nature of toxicological emergencies, as outlined in EMS protocols. Another incorrect approach is to administer antidotes without a confirmed or highly suspected specific overdose. For example, administering naloxone without evidence of opioid overdose or flumazenil without a clear history of benzodiazepine overdose can be ineffective and potentially harmful, masking symptoms or causing adverse effects. This demonstrates a lack of systematic assessment and a departure from evidence-based treatment algorithms, which emphasize targeted interventions based on clinical presentation and history. This is a failure to adhere to the principle of treat the patient, not the monitor, and a misapplication of pharmacologic interventions. A third incorrect approach is to dismiss the patient's symptoms as solely related to withdrawal, without a thorough toxicological assessment. While withdrawal can present with serious symptoms, it is crucial to rule out acute overdose or other emergent conditions that may mimic withdrawal. Failing to consider a primary toxicological event can lead to misdiagnosis and inappropriate management, potentially resulting in severe harm or death. This represents a failure to conduct a comprehensive differential diagnosis and a premature conclusion based on a single aspect of the patient's history. Professional reasoning. Professionals should employ a structured approach to toxicological emergencies, beginning with scene safety and rapid patient assessment. The 5 rights of medication administration, right patient, right drug, right dose, right route, right time are critical, especially when administering antidotes. A thorough history including the what, when, how much, and how of the exposure is essential. Understanding the patient's underlying medical conditions and potential for co-ingestions or withdrawal is also vital. Decision-making should be guided by established protocols, toxicological resources, e.g., Poison Control Center, and the patient's clinical status, always prioritizing rapid transport to an appropriate facility when indicated. Question 12. The evaluation methodology shows a 68-year-old male found unresponsive in his living room. His wife states he was complaining of severe chest pain radiating to his left arm approximately 30 minutes prior to discovery, but he refused to go to the hospital. On your arrival, he is apneic, pulseless, and has a pale, diaphoretic appearance. His wife is distraught and insists he has a history of anxiety. Which of the following per-hospital management strategies is most appropriate? Option A. Initiate immediate cardiopulmonary resuscitation, CPR, and advanced airway management, prepare for rapid transport to the nearest appropriate medical facility, and administer aspirin and nitroglycerin if available and indicated by protocol. Option B. Administer oxygen via non-rebreather mask, obtain a 12-lead electrocardiogram, ECG, and attempt to gather more detailed information about his anxiety history from his wife. Option C. Focus on calming the patient and his wife, reassuring them that his symptoms are likely due to anxiety, and monitor his vital signs closely while awaiting physician consultation. Option D. Begin chest compressions and administer a bolus of intravenous fluids, then reassess his pulse and breathing before considering further interventions. The correct answer is A. Initiate immediate cardiopulmonary resuscitation, CPR, and advanced airway management, prepare for rapid transport to the nearest appropriate medical facility, and administer aspirin and nitroglycerin if available and indicated by protocol. Explanation. The evaluation methodology shows a scenario that is professionally challenging due to the inherent ambiguity of a patient presenting with symptoms that could indicate a life-threatening condition, but also have benign explanations. The per-hospital provider must rapidly assess, differentiate, and initiate appropriate management without the benefit of advanced diagnostic tools or physician oversight readily available in a hospital setting. This requires a high degree of clinical judgment, adherence to established protocols, and a thorough understanding of potential differential diagnoses. The correct approach represents best professional practice by prioritizing immediate life-saving interventions based on the most critical potential diagnoses, while simultaneously initiating a systematic assessment to refine the diagnosis and guide further management. This aligns with the core principles of emergency medical services as defined by the American Board of Emergency Medicine Subspecialty, in EMS, emphasizing rapid patient stabilization and transport to definitive care. The regulatory framework for EMS in the United States, as overseen by bodies like NHTSA and state EMS agencies, mandates that per-hospital providers operate within their scope of practice, follow established protocols, and make evidence-based decisions to ensure patient safety and optimal outcomes. This approach prioritizes the ABCs: airway, breathing, circulation, and addresses immediate threats to life, which is a fundamental tenet of EMS care. An incorrect approach that focuses solely on a less critical symptom without considering the potential for a more severe underlying cause represents a failure to adhere to the principle of treat the worst first. This could lead to delayed or missed critical interventions, violating the ethical obligation to provide the highest standard of care. For instance, if a patient has mild abdominal pain, but also signs of shock, focusing only on the pain without addressing the shock is a significant clinical and ethical failure. Another incorrect approach might involve delaying transport to gather more information or perform extensive, non-emergent procedures in the per-hospital setting. This violates the principle of timely transport to definitive care, which is crucial for conditions that require immediate hospital-based interventions. Furthermore, deviating from established protocols without clear clinical justification constitutes a regulatory failure, as EMS providers are expected to operate within the guidelines set forth by their certifying and licensing bodies. Professional decision-making in such situations should follow a structured approach. 1. Scene safety and initial impression. Quickly assess the environment and the patient's general appearance. 2. Primary survey update. Address immediate life threats to airway, breathing, circulation, disability, neurological status, and exposure. 3. Focused history and physical exam. Gather relevant information and perform a targeted assessment based on the initial impression. 4. Differential diagnosis. Consider the most likely and most dangerous causes of the patient's presentation. 5. Treatment and intervention. Initiate interventions based on protocols and the patient's condition, prioritizing life-saving measures. 6. Reassessment. Continuously monitor the patient's response to interventions and adjust the treatment plan as needed. 7. Transport decision. Determine the appropriate destination and mode of transport based on the patient's condition and the capabilities of receiving facilities. Question 13. Strategic planning requires EMS agencies to develop protocols that effectively address the unique physiological and anatomical characteristics of pediatric patients. When responding to a pediatric emergency, which of the following approaches best reflects the necessary adaptation of standard EMS protocols to ensure optimal patient care, considering the differences between adult and pediatric anatomy and physiology? Option A. Adapting airway management techniques to account for the smaller caliber and higher position of the pediatric airway, and adjusting medication dosages based on weight-specific pediatric guidelines. Option B. Prioritizing immediate transport to the nearest emergency department without a detailed, age-specific assessment to minimize scene time. Option C. Implementing standard adult assessment and treatment algorithms, assuming that basic life support principles are universally applicable across all age groups. Option D. Relying on the intuition of the most experienced paramedic on scene to make critical treatment decisions, as experience often supersedes specific pediatric knowledge. The correct answer is C. Implementing standard adult assessment and treatment algorithms, assuming that basic life support principles are universally applicable across all age groups. Explanation. This scenario is professionally challenging because it requires the EMS provider to adapt standard adult protocols to a pediatric patient, where anatomical and physiological differences can significantly impact assessment and treatment. Failure to recognize and account for these differences can lead to delayed or inappropriate interventions, potentially worsening patient outcomes. Careful judgment is required to prioritize interventions based on the unique vulnerabilities of children. The correct approach represents best professional practice because it directly addresses the core of pediatric EMS care, understanding and applying age-appropriate physiology. By recognizing that a child's smaller airway, higher metabolic rate, and different cardiovascular response to stress necessitate specific considerations, the provider ensures that assessment and treatment are tailored to the patient's developmental stage. This aligns with the overarching principles of patient safety and evidence-based practice mandated by the American Board of Emergency Medicine, ABEM. Subspecialty in Emergency Medical Services, which emphasizes the need for specialized knowledge in diverse patient populations. The focus on the unique aspects of pediatric anatomy and physiology, such as the proportionally larger head, narrower airway, and immature thermoregulation, directly informs appropriate airway management, fluid resuscitation, and medication dosing, all critical for pediatric resuscitation. An incorrect approach that relies solely on adult protocols fails to acknowledge the fundamental differences in pediatric anatomy and physiology. This represents a significant regulatory and ethical failure. Specifically, it violates the principle of providing care commensurate with the provider's training and the patient's needs. The ABEM subspecialty in EMS expects providers to possess advanced knowledge and skills, including the ability to differentiate and manage pediatric emergencies effectively. Applying adult-centric approaches to children can lead to misinterpretation of vital signs. Incorrect medication dosages, e.g., adult doses being toxic to children, and inadequate airway management, all of which can have severe, life-threatening consequences. This approach demonstrates a lack of understanding of pediatric pathophysiology, a critical component of the subspecialty's curriculum and practice standards. Another incorrect approach that prioritizes rapid transport without a thorough, age-appropriate assessment is also professionally unacceptable. While rapid transport is often crucial in EMS, it cannot replace a foundational understanding of the patient's condition. For a pediatric patient, a rapid assessment must still incorporate an awareness of their unique physiological characteristics. For example, a child in respiratory distress may present with different signs and symptoms than an adult, and a hasty transport, without recognizing these subtle but critical differences, could mean missing a crucial intervention at the scene or misdiagnosing the underlying cause. This approach neglects the specific knowledge required for pediatric assessment, which is a cornerstone of the ABEM subspecialty in EMS. The professional decision-making process for similar situations should involve a systematic approach. 1. Recognize the patient population. Immediately identify the patient as pediatric. 2. Activate pediatric-specific knowledge. Recall and apply knowledge of pediatric anatomy, physiology, and common pediatric emergencies. 3. Perform an age-appropriate assessment. Utilize pediatric assessment tools and interpret findings in the context of normal pediatric ranges and developmental stages. 4. Tailor interventions. Adapt standard EMS protocols to account for pediatric differences in airway, breathing, circulation, and medication administration. 5. Prioritize based on pediatric vulnerabilities. Understand which physiological systems are most compromised in children and focus interventions accordingly. 6. Consult and transport. Determine the most appropriate destination and transport strategy based on the patient's condition and the capabilities of receiving facilities, ensuring continuous, age-appropriate care en route. Question 14. Investigation of a 4-month-old infant presenting with increased work of breathing, characterized by nasal flaring, grunting respirations, and mild retractions, accompanied by a respiratory rate of 50 breaths per minute and an oxygen saturation of 92% on room air. The infant is awake and alert but appears uncomfortable. Which of the following initial management strategies is most appropriate for this pediatric patient in the pre-hospital setting? Option A. Immediately administer a nebulized bronchodilator while preparing for transport. Option B. Focus on obtaining a detailed birth and feeding history from the parents before any intervention. Option C. Begin immediate transport to the nearest emergency department without pre-hospital interventions. Option D. Administer high-flow oxygen via a non-rebreather mask and initiate continuous pulse oximetry monitoring. Correct answer is D. Administer high-flow oxygen via a non-rebreather mask and initiate continuous pulse oximetry monitoring. Explanation. Scenario analysis. This scenario presents a common yet critical pediatric emergency, respiratory distress in an infant. The challenge lies in rapidly assessing the severity of distress, identifying the underlying cause, and initiating appropriate interventions while considering the unique physiological vulnerabilities of infants. The potential for rapid deterioration necessitates a systematic and evidence-based approach, adhering strictly to established pediatric emergency medical services, EMS, protocols, and guidelines. The professional challenge is amplified by the need to balance emergent treatment with the importance of minimizing patient distress and involving caregivers appropriately. Correct approach analysis. The correct approach prioritizes immediate assessment of airway, breathing, and circulation, ABCs, and the administration of supplemental oxygen. This aligns with established pediatric resuscitation guidelines, such as those from the American Heart Association, AHA, and the American Academy of Pediatrics, OP, which are foundational to EMS practice in the United States. Prompt oxygenation is crucial for infants experiencing respiratory distress, as their metabolic rate is high and their reserve is limited. Early identification of retractions, nasal flaring and grunting, coupled with auscultation for breath sounds, guides further management. The use of a non-rebreather mask or bag valve mask ventilation, depending on the severity of distress and oxygen saturation, is a standard intervention. This approach reflects best professional practice by adhering to evidence-based protocols designed to stabilize the patient and prevent further compromise. Incorrect approach is analysis. One incorrect approach would be to delay oxygen administration while focusing solely on obtaining a detailed history from the parents. While history is important, in a critically ill infant with respiratory distress, immediate life support takes precedence. Failure to provide prompt oxygenation constitutes a failure to adhere to fundamental pediatric resuscitation principles and could lead to hypoxia and irreversible organ damage, representing a significant ethical and professional lapse. Another incorrect approach would be to administer a bronchodilator without first ensuring adequate oxygenation and ventilation. While bronchospasm can be a component of respiratory distress, it is not the universal cause, and administering a bronchodilator in a hypoxic infant without addressing the underlying oxygenation deficit can be ineffective and delay crucial interventions. This deviates from a systematic, ABC prioritized approach and could be considered a failure to follow established EMS protocols. A third incorrect approach would be to immediately transport the infant without any pre-hospital intervention, assuming definitive care will be provided at the hospital. This overlooks the critical role of EMS in stabilizing patients and improving outcomes. Delaying essential interventions like oxygen therapy during transport can lead to a worse patient outcome and represents a failure to provide the highest level of care within the EMS scope of practice. Professional reasoning. Professionals should employ a systematic approach to pediatric emergencies, beginning with a rapid primary survey, ABCs. This is followed by a secondary survey and the collection of relevant history. Crucially, interventions should be initiated concurrently with assessment, prioritizing life-sustaining measures. For respiratory distress, this means ensuring a patent airway, assessing breathing effectiveness, and providing supplemental oxygen as indicated by the patient's condition and vital signs. Continuous reassessment of the patient's response to interventions is paramount. This decision-making process is guided by established protocols, clinical judgment, and a commitment to providing the best possible care within the EMS scope of practice, always with the patient's well-being as the primary objective. Question 15. What factors determine the appropriate method for obtaining a patient's medical history and consent for information sharing when the patient is conscious but experiencing acute respiratory distress and their spouse is present and eager to provide details? Option A. The spouse's insistence on providing information and the perceived urgency of the situation, overriding the need to assess the patient's capacity. Option B. The EMS provider's assessment of the patient's capacity to consent and the urgency of obtaining critical medical information, balanced with the patient's right to privacy and dignity. Option C. The spouse's immediate willingness to sign any necessary consent forms and the provider's desire to expedite patient transport. Option D. The EMS provider's familiarity with the patient's medical history and the spouse's perceived trustworthiness. The correct answer is B. The EMS provider's assessment of the patient's capacity to consent and the urgency of obtaining critical medical information, balanced with the patient's right to privacy and dignity. Explanation. Scenario analysis. This scenario is professionally challenging because the EMS provider must balance the immediate need for critical patient information with the patient's right to privacy and dignity, especially when the patient is in distress and potentially unable to fully consent. The provider must also consider the legal and ethical implications of obtaining information from a third party when the patient is present but incapacitated. Correct approach analysis. The correct approach prioritizes obtaining consent directly from the patient whenever possible, even if it requires additional communication effort. This aligns with the fundamental ethical principle of patient autonomy and the legal requirements for informed consent, as mandated by U.S. federal regulations such as HIPAA, Health Insurance Portability and Accountability Act, and state-specific patient rights laws. When a patient is unable to provide full consent due to their medical condition, the provider must seek the least intrusive means of gathering necessary information while respecting the patient's presumed wishes and involving a surrogate decision-maker if available and appropriate, as outlined in EMS protocols and state medical practice acts. This approach ensures that patient information is handled lawfully and ethically, minimizing the risk of privacy violations. Incorrect approach is analysis. Gathering information solely from the family member without attempting to assess the patient's capacity or obtain their assent, even if limited, violates the principle of patient autonomy and may contravene HIPAA minimum necessary standard if the information obtained is broader than what is essential for immediate care. This approach risks unauthorized disclosure of protected health information. Assuming the patient's consent based on their relationship with the family member is a significant ethical and legal misstep. U.S. healthcare law and ethical guidelines emphasize direct patient interaction and consent. Without assessing the patient's capacity or obtaining their assent, this approach can lead to breaches of privacy and trust, and potential legal repercussions for the EMS agency. Delaying care to conduct a lengthy capacity assessment before gathering any information from the family member could be detrimental to the patient's immediate medical needs, potentially violating the EMS provider's duty to provide timely care. However, completely disregarding the need to assess capacity and obtain consent, even in an emergency, is also a failure. The correct approach involves a dynamic assessment of both the patient's condition and the urgency of information gathering. Professional reasoning. EMS providers should employ a tiered approach to patient history taking and communication. First, attempt direct communication and consent from the patient. If the patient lacks capacity, assess for the presence of a surrogate decision maker and obtain information and consent from them, while still attempting to gain assent from the patient if possible. Document all efforts to obtain consent and the rationale for proceeding with information gathering from a surrogate. Adherence to HIPAA, state medical practice acts, and agency protocols is paramount. Question 16. When evaluating a 78-year-old male found sitting on his living room floor with a reported history of multiple falls in the past year, who is now exhibiting mild confusion and is unable to recall the events leading up to his current position, what is the most appropriate initial approach for an EMS crew to take, adhering strictly to U.S. regulatory frameworks and ABEM EMS subspecialty guidelines? Option A. Rely on the patient's statement that he just fell and proceed with transport without further extensive questioning or examination, as his age and history of falls suggest this is a common occurrence. Option B. Assume the confusion is a direct result of the fall and focus solely on assessing for obvious signs of trauma, such as lacerations or deformities. Option C. Conduct a thorough head-to-toe physical examination. Obtain a detailed history from the patient and any available family or caregivers. Assess vital signs, and inquire about recent medication changes or adherence issues. Option D. Administer a mild sedative to calm the patient and reduce agitation, then transport him to the nearest hospital for further evaluation. The correct answer is C. Conduct a thorough head-to-toe physical examination. Obtain a detailed history from the patient and any available family or caregivers. Assess vital signs, and inquire about recent medication changes or adherence issues. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medical services. A geriatric patient experiencing a change in mental status with a history of falls and potential medication non-adherence. The professional challenge lies in differentiating between a benign age-related change, a consequence of a fall, an acute medical illness, or a medication-related issue, all while adhering to established protocols and ensuring patient safety and dignity. The urgency of the situation, coupled with the patient's potential vulnerability and communication difficulties, necessitates a systematic and evidence-based approach. Correct approach analysis. The correct approach prioritizes a comprehensive assessment that includes gathering information from multiple sources, performing a thorough physical examination, and considering the patient's baseline status and recent history. This aligns with the American Board of Emergency Medicine's emphasis on evidence-based practice and patient-centered care within the EMS framework. Specifically, it reflects the guidelines for geriatric emergency care, which stress the importance of a holistic assessment to identify underlying causes of altered mental status and fall risk in older adults. This approach ensures that all potential contributing factors are considered, leading to a more accurate diagnosis and appropriate treatment plan, thereby upholding the ethical obligation to provide the highest standard of care. Incorrect approach is analysis, an approach that solely focuses on the most obvious symptom, e.g., confusion, without a broader assessment risks missing critical underlying pathology. This is a regulatory failure as it deviates from the comprehensive assessment mandated by EMS protocols and best practices for geriatric patients, potentially leading to delayed or incorrect treatment. An approach that dismisses the patient's symptoms as just old age is a significant ethical and professional failure. It demonstrates ageism and a lack of due diligence, violating the principle of providing equitable care to all patients regardless of age. This also fails to meet the regulatory requirement of thoroughly investigating the cause of the patient's presentation. An approach that relies solely on a single piece of information, such as a reported fall, without corroborating evidence or further investigation, is insufficient. This can lead to misdiagnosis and inappropriate management, failing to meet the standard of care expected in emergency medicine and potentially violating patient safety regulations. Professional reasoning. Professionals should employ a structured approach to geriatric emergencies, starting with scene safety and initial impression, followed by a systematic assessment that includes a detailed history from patient and collateral sources, a focused physical examination, and consideration of the patient's baseline functional status. This framework allows for the identification of red flags and the formulation of a differential diagnosis. In cases of altered mental status in the elderly, a high index of suspicion for serious underlying conditions is warranted, and a thorough investigation is crucial. Decision-making should be guided by established EMS protocols, clinical guidelines for geriatric care, and a commitment to patient advocacy. Question 17. The monitoring system demonstrates a continuous downward trend in the child's respiratory rate and a paradoxical decrease in peripheral oxygen saturation, despite supplemental oxygen administration in a 4-year-old male involved in a motor vehicle collision. The patient is conscious but lethargic, with a palpable but rapid pulse. Which of the following pre-hospital management strategies is most appropriate given these findings? Option A. Initiate immediate airway management with positive pressure ventilation and prepare for rapid transport to the nearest appropriate trauma center. Option B. Focus on splinting suspected extremity fractures and administering pain medication. Option C. Reassess the mechanism of injury and search for occult injuries before initiating aggressive interventions. Option D. Continue to monitor vital signs closely, administer additional intravenous fluids, and reassess in 5 minutes. The correct answer is A. Initiate immediate airway management with positive pressure ventilation and prepare for rapid transport to the nearest appropriate trauma center. Explanation. This scenario is professionally challenging due to the inherent vulnerability of pediatric patients in trauma situations and the critical need for rapid, accurate assessment and intervention within the pre-hospital environment. The complexity arises from the potential for rapid physiological decompensation in children, subtle signs of injury, and the ethical imperative to provide the highest standard of care while adhering to established protocols and resource limitations. Careful judgment is required to balance the urgency of the situation with the need for a systematic and evidence-based approach. The correct approach represents best professional practice because it prioritizes a structured, age-appropriate assessment that directly addresses the unique physiological and anatomical differences in pediatric trauma. This aligns with the American Board of Emergency Medicine's ABEM focus on evidence-based medicine and the application of specialized knowledge in emergency medical services, EMS. Specifically, it emphasizes the use of validated pediatric assessment tools and a systematic approach to identify and manage life-threatening injuries, ensuring that interventions are tailored to the child's developmental stage and physiological status. This adheres to the principles of patient safety and quality improvement, core tenets of EMS practice as outlined by relevant U.S. regulatory frameworks governing EMS provider education and practice. An incorrect approach that focuses solely on adult protocols fails to recognize the significant physiological differences in pediatric patients, such as a higher metabolic rate, different mechanisms of shock presentation, and a greater susceptibility to hypothermia. This can lead to delayed or inappropriate treatment, potentially exacerbating injuries or leading to adverse outcomes, and represents a failure to meet the standard of care expected for pediatric patients. Another incorrect approach that bypasses established protocols in favor of immediate, potentially unguided interventions risks deviating from evidence-based practices and could lead to errors in judgment or treatment. This undermines the systematic approach to patient care and quality assurance mandated by EMS regulations. A third incorrect approach that delays definitive care by focusing on non-critical aspects without a comprehensive assessment of life threats ignores the rapid deterioration potential in pediatric trauma and violates the principle of prioritizing life-saving interventions. This demonstrates a lack of understanding of pediatric resuscitation priorities and a failure to adhere to established EMS guidelines for trauma management. Professional decision-making in similar situations requires a robust understanding of pediatric physiology and trauma management principles, coupled with the ability to apply these within the constraints of the pre-hospital environment. This involves a systematic assessment, including a primary survey, airway, breathing, circulation, disability, exposure, adapted for pediatrics, followed by a secondary survey. Crucially, it necessitates the use of age-appropriate equipment and medication dosages, and a clear understanding of when to escalate care and transport to a higher level of trauma facility. Adherence to established EMS protocols, continuous professional development, and a commitment to patient advocacy are essential for ensuring optimal outcomes in pediatric trauma. Question 18. The performance metrics show a consistent trend of delayed initiation of advanced neurological interventions for patients presenting with suspected acute stroke symptoms, often attributed to challenges in obtaining informed consent from patients with altered mental status. You are responding to a patient found unresponsive at home, with EMS dispatch noting a possible seizure. Upon arrival, the patient exhibits focal neurological deficits and is unable to communicate coherently. Which of the following represents the most appropriate course of action in this emergent situation, adhering to U.S. regulatory and ethical frameworks for emergency medical services? Option A. Proceed with definitive treatment based on implied consent for life-saving measures, as the patient is clearly incapacitated and requires immediate intervention, and document the assessment of incapacity and the rationale for proceeding. Option B. Initiate immediate life-saving interventions and advanced neurological protocols for suspected stroke, while simultaneously attempting to locate a family member or legal guardian to obtain consent. Option C. Assume the patient has the capacity to consent to treatment despite their current presentation, and proceed with standard stroke protocols after a brief verbal confirmation of their willingness to be treated. Option D. Delay all advanced neurological interventions until a family member or legal guardian can be contacted and provide informed consent to ensure full compliance with patient autonomy. The correct answer is B. Initiate immediate life-saving interventions and advanced neurological protocols for suspected stroke, while simultaneously attempting to locate a family member or legal guardian to obtain consent. Explanation. This scenario presents a professional challenge due to the inherent tension between rapid patient assessment and treatment in a time-sensitive neurological emergency, and the ethical obligation to obtain informed consent, especially when a patient's capacity to consent may be compromised. The pressure to act quickly to preserve neurological function must be balanced with patient autonomy and legal requirements. The correct approach represents best professional practice because it prioritizes patient safety and well-being, while adhering to established ethical and legal principles for managing patients with suspected neurological emergencies who may lack capacity. This involves a systematic assessment of the patient's ability to consent, seeking surrogate consent when necessary, and documenting these steps meticulously. This aligns with the principles of beneficence, acting in the patient's best interest, and respect for autonomy, even when autonomy is diminished. The legal framework in the U.S., as governed by state laws and federal regulations like EMTALA, generally supports implied consent for life-saving interventions when a patient is incapacitated and no surrogate is immediately available, but it also mandates efforts to obtain consent or surrogate consent when feasible. An incorrect approach that involves proceeding with definitive treatment without attempting to assess capacity or obtain surrogate consent fails to uphold patient autonomy and may violate legal and ethical standards. This could lead to legal repercussions and ethical breaches, as it bypasses the patient's right to self-determination. Another incorrect approach, delaying critical intervention solely to locate a surrogate when the patient is clearly incapacitated and in need of immediate life-saving care, could result in irreversible neurological damage, violating the principle of beneficence and potentially leading to adverse patient outcomes and professional liability. A third incorrect approach, assuming capacity without any assessment, is also professionally unacceptable, as it ignores the potential for altered mental status in neurological emergencies and the need for a formal capacity assessment. Professionals should employ a decision-making framework that begins with a rapid assessment of the patient's neurological status and immediate need for intervention. Simultaneously, they should assess the patient's capacity to understand their condition, the proposed treatment, and the risks and benefits of that treatment. If capacity is questionable or absent, the next step is to diligently seek a surrogate decision-maker. If a surrogate is unavailable and the situation is life-threatening, implied consent for necessary interventions is generally accepted under U.S. law, but this must be clearly documented. Throughout this process, clear and thorough documentation of all assessments, decisions, and actions is paramount. Question 19. The monitoring system demonstrates a patient presenting with symptoms suggestive of a serious medical condition, yet the patient is lucid, articulate, and adamantly refuses any further medical intervention or transport to the hospital. The paramedic has assessed the patient and believes transport is medically indicated. What is the most appropriate course of action? Option A. Override the patient's refusal and transport them to the nearest hospital, as the paramedic's clinical judgment indicates a need for immediate medical intervention. Option B. Assess the patient's capacity to refuse treatment. If capacity is confirmed, document the refusal thoroughly, including the patient's understanding of the risks and benefits, and provide appropriate advice for follow-up care before concluding the encounter. Option C. Attempt to persuade or pressure the patient into accepting transport by emphasizing the severity of their condition and the potential negative outcomes of refusal. Option D. Leave the scene immediately without further assessment or documentation, as the patient has refused care and the paramedic's role is complete. The correct answer is B. Assess the patient's capacity to refuse treatment. If capacity is confirmed, document the refusal thoroughly, including the patient's understanding of the risks and benefits, and provide appropriate advice for follow-up care before concluding the encounter. Explanation. Scenario analysis. This scenario presents a professional challenge rooted in the conflict between immediate patient care needs and the established legal and ethical obligations of EMS providers. The paramedic is faced with a situation where a patient's condition appears to be deteriorating, but the patient is refusing transport and treatment. This creates a tension between the principle of beneficence, acting in the patient's best interest, and the principle of autonomy, respecting the patient's right to make their own decisions. Navigating this requires careful judgment to ensure patient safety while upholding legal and ethical standards. Correct approach analysis. The correct approach involves a thorough assessment of the patient's capacity to refuse treatment. This is paramount because a patient's refusal is only legally and ethically valid if they possess the mental capacity to understand their condition, the proposed treatment, the risks and benefits of treatment, and the consequences of refusing treatment. If capacity is present, the paramedic must document the refusal meticulously, including the patient's understanding and the rationale for their decision, and then respect that decision, providing appropriate advice and instructions for follow-up care. This aligns with the ethical principle of autonomy and the legal requirement to respect a competent adult's right to refuse medical intervention. Incorrect approach is analysis. One incorrect approach is to override the patient's refusal based solely on the paramedic's clinical judgment that the patient needs transport. This violates the principle of autonomy and the legal right of a competent individual to refuse medical care, even if that refusal seems unwise to the provider, could lead to accusations of battery or false imprisonment. Another incorrect approach is to abandon the patient without a comprehensive assessment of their capacity and without providing any advice or documentation. This fails to meet the standard of care, as EMS providers have a duty to assess and document the situation thoroughly, even in cases of refusal. It also neglects the ethical obligation to provide some level of care, such as education and advice, to mitigate potential harm. A third incorrect approach is to coerce or unduly influence the patient into accepting transport. This undermines the patient's autonomy and can be considered unethical and potentially illegal. The goal is to ensure the patient's decision is informed and voluntary, not the result of pressure. Professional reasoning. Professionals should employ a structured decision-making process that prioritizes patient capacity assessment. This involves 1. Performing a comprehensive medical assessment to understand the patient's condition. 2. Assessing the patient's mental capacity to make informed decisions, which includes evaluating their understanding of the situation, treatment options, and consequences of refusal. 3. If capacity is present, clearly explaining the risks of refusal and the benefits of transport/treatment. 4. If the patient still refuses, meticulously documenting the entire encounter, including the capacity assessment, the patient's stated reasons for refusal, and any advice or instructions provided. 5. If capacity is questionable or absent, proceeding with appropriate interventions as per protocol and legal guidelines, which may involve seeking consent from a surrogate decision maker or transporting the patient for evaluation. Question 20. The evaluation methodology shows that a newly appointed EMS medical director is faced with a high volume of reported protocol deviations and a perceived lack of physician engagement in quality improvement initiatives. The director must decide on the most effective initial strategy to enhance medical oversight and leadership within the system. Which of the following strategies best addresses the immediate and long-term needs for robust medical direction? Option A. Implement a comprehensive physician leadership development program focused on quality improvement methodologies and protocol stewardship, while simultaneously establishing a structured peer review process for all reported deviations. Option B. Delegate the primary responsibility for investigating protocol deviations and developing corrective actions to experienced paramedics, with the medical director providing only periodic oversight. Option C. Immediately suspend all non-essential EMS provider training until all reported protocol deviations are individually investigated and resolved by the medical director. Option D. Focus exclusively on updating all existing medical protocols to reflect the latest evidence-based guidelines, assuming this will inherently resolve most deviation issues. The correct answer is A. Implement a comprehensive physician leadership development program focused on quality improvement methodologies and protocol stewardship, while simultaneously establishing a structured peer review process for all reported deviations. Explanation. This scenario presents a professional challenge due to the inherent tension between immediate patient care needs and the long-term strategic development of EMS medical direction. A medical director must balance the imperative to address current clinical issues with the responsibility of fostering a sustainable, high-quality medical system. Careful judgment is required to prioritize interventions that have the greatest impact on patient outcomes and system integrity, while also considering resource allocation and the development of future medical leadership. The correct approach represents best professional practice because it aligns with the core tenets of medical oversight as defined by the American Board of Emergency Medicine, ABEM. Subspecialty in emergency medical services. This approach prioritizes the establishment of robust medical direction infrastructure, including clear protocols, ongoing quality assurance, and the development of physician leaders who can champion evidence-based practice and patient safety. It acknowledges that effective medical oversight is not solely reactive, but requires proactive strategic planning and investment in human capital. This aligns with regulatory expectations for physician leadership in EMS systems, emphasizing accountability for the medical care provided. An incorrect approach that focuses solely on immediate protocol deviations, without addressing the underlying systemic issues, fails to meet the comprehensive responsibilities of medical direction. This represents a regulatory failure by neglecting the systematic improvement of care and potentially allowing recurring problems to persist. Ethically, it prioritizes a superficial fix over a sustainable solution, potentially impacting patient care in the long run. Another incorrect approach that delegates all medical oversight responsibilities to non-physician personnel without adequate physician supervision is a significant regulatory and ethical failure. This violates the principle of physician accountability for medical care and can lead to a breakdown in the chain of medical command and the implementation of evidence-based practices. It undermines the physician's ultimate responsibility for the quality and safety of EMS medical care. A third incorrect approach that prioritizes administrative tasks over clinical oversight demonstrates a misunderstanding of the medical director's primary role. While administrative duties are necessary, they should support, not supplant, the core function of ensuring high-quality medical care. This approach risks a decline in clinical standards and a failure to identify and address critical patient care issues, representing a deviation from expected professional practice and potentially violating regulatory mandates for active medical leadership. The professional reasoning process for similar situations should involve a hierarchical prioritization of responsibilities. First, ensure immediate patient safety and address critical clinical issues. Second, assess the systemic causes of these issues and develop strategies for long-term improvement. Third, invest in the development of personnel and infrastructure to support ongoing quality and leadership. Finally, continuously evaluate and adapt the medical direction program based on data and evolving best practices, always maintaining physician accountability.